So I'm going to talk to you today about the prosthetic treatment for glenohumeral arthritis. I tend to give talks that are more global in applicability. So if I stood here and talked about the treatment of rheumatoid arthritis with shoulder replacement, that'd be a little focused. But I want to look at the whole problem itself. Glenohumeral arthritis is not the problem that osteoarthritis of the hip is, or knee osteoarthritis. If you look at this, at the number of joint replacements that get done in this country each year, there's probably about 450,000 hip replacements, probably about 650,000 knee replacements, and probably upwards of 70 or 80,000 shoulder replacements of one type or another. So it's growing, all right, because 10 years ago it was probably more like 25 or 30,000. It's something you're going to see in your practice, unless you're a pediatric orthopedist, right, or a tumor surgeon. But even tumor surgeons are going to have to do something about around the shoulder with respect to prostheses. So this is what we're going to talk about, and these are my disclosures. But most relevant for this is I do have a, I'm going to stand over here and make it easier. I'm not sure I can actually talk from the right-hand side, so I'm going to try that. This is kind of like, which side of the bed you sleep on when you're married, right? Okay. I sleep, as you face the bed, I sleep on the left. That may be more information than you actually wanted, right? Okay. But one time, we'll just go with the concept, not the visual, okay? Okay. So one time my wife and I actually had to try and switch for some reason or another, and it was absolutely impossible to switch sides, right? Because then you're looking the wrong way and the whole thing. But I'm going to do my best, right, to speak from this side of the room. So these are my disclosures. Most relevant for this is that I am a design surgeon for an arthroplasty system. You'll see some slides about that. This talk is applicable to any shoulder arthroplasty system. When I had to make up this slide recently, I realized that somehow in the last 5 years I've gotten involved in a lot of things. All right, some of them not for profit, some of them for profit, and so I wonder why I did it. But when it adds up, it makes me think about it. So glenohumeral arthritis. If you've seen one case of glenohumeral arthritis, you've seen one case of glenohumeral arthritis. That's what it is. This is just a simple spectrum of what you can expect to see in patients that will present with some degree of degeneration of the glenohumeral joint. Right? This is a partial listing of the type of implants that can be used to treat glenohumeral arthritis. A partial listing, and you'll see that as we go later on. So somehow or another, you have to put these together, right, and figure out what to do. So decision making is critically important, right? When a patient walks into your room, you have to integrate an understanding of the patient as well as the nature of the underlying arthritis. And when I think about that, in the patient in my room, I think about the clinical manifestations of it, the radiographic manifestations, whatever imaging studies you have, as well as the pathoanatomy, the things you can see on X-ray and the things you can't see that you may see with an MRI when you look at the soft tissues. So that's what medicine is all about, decision making. Then you have to understand the armamentarium of options you have with respect to prosthetic implants. What can one type of design achieve versus another design? What patient is it appropriate for? And you have to match these two together to figure out what to do. So this is an equation that that I put in this, and you'll see this a number of times. The patient, the disease process, and the implant options for glenohumeral arthritis gives you a treatment plan. Now, there's nothing special about this slide with respect to glenohumeral arthritis. This applies to every clinical condition that you treat in orthopedics. And whether it's somebody with a club foot, with somebody with hip osteoarthritis, somebody with an ACL tear, you have, except for the implant options, you have to decide, what about the patient that's unique, what about the disease process or the condition of the injury that's unique, and combine that with the different treatment options you have to develop a treatment plan. And a bone patella bone ACL reconstruction in one patient may be appropriate, whereas a cadaver reconstruction may be more appropriate in another one. So this is clearly something that applies to virtually every patient who's going to walk into your office or clinic. So let's think about this in relation to glenohumeral arthritis. So pathoanatomy, it refers to three areas as far as I'm concerned. First is the glenoid. When I look at the glenoid, you have to think about things like bone quality, Osteopenia, frequently seen, particularly in patients with inflammatory arthritis. The cysts that may be present on the glenoid side, and the quantity of bone, the degree of erosion. Glenoid erosion is a common finding in patients with glenohumeral arthritis. So, does this point?
Does it point?
It's usually the same color.
Really? Okay, that's good. So this is a mid-course correction. This doesn't point, but I can. All right? Okay. That's, of course, I don't know if I can do it from the right side here. So obviously, you look at this. This degree of glenoid pathology is considerably different than this degree, right? But this degree has significant posterior erosion. And you look at this. This is the mother of all posterior erosion, because look how this is basically, this is a 30 to 40 degrees of retroversion of the glenoid. So understanding the anatomy of the glenoid is very important. It is a small piece of bone. It's like a golf tee. Right? You can put a ball on a golf tee, but if you slice off the 3 or 4 millimeters, you're smiling. You're probably a golfer, right? Okay? If you slice off the upper end of a golf tee, what happens when you try and put the ball on it? It falls off. Same thing with the humeral head. If you don't have enough bone there, it's going to sublux one way or the other. And think about the humerus. The humerus doesn't get as much attention as it should, right? But it's worthy of it, because usually the humerus we can correct things. But when you think about this, right? This is not only glenoid pathology, but this is humeral pathology. This would be described in textbooks in the 60s and 70s as arthritis mutilans, right? This is uncontrolled inflammatory arthritis, right? And this, you used to see patients come in with 6 joints that looked like this. Before we had more appropriate and effective treatments for inflammatory arthritis, the classic rheumatoid arthritis. That's why in this country there were multidisciplinary arthritis centers that were set up by the federal government to treat all the patients with rheumatoid arthritis. You don't see that anymore because we have much more effective treatments. Obviously, this is not as much a big deal as this down here. This would be considered inadequate fixation of that fracture. So understanding the anatomy of the proximal humerus or the humeral shaft is important, because no matter how I try, I don't have a prosthesis that can make a right angle like that. And then there's the soft tissues, which tend to be neglected, but around the shoulder are very important. When you think about a knee replacement, you're going to focus on the quadriceps mechanism, the extensor mechanism. Around the hip, you focus on the abductors. Around the shoulder, you really have to focus on more of the soft tissues. Right? The deltoid and rotator cuff are critically important to the function of almost any implant. The absence of one may push you down a certain direction versus the absence or function of another. So the rotator cuff, is it intact? If it's torn, is it repairable? If it's not repairable, right, what options do we have? And the deltoid. When you operate on patients that have had previous rotator cuff surgery, even arthroscopic surgery, there's frequently some compromise of the deltoid, and you have to factor that into it. So when you look about the development of shoulder arthroplasty, this is just, I put this up here for historical value, and as well as some interest as well. So look at this, right? What do you think this looks like? Looks like a total hip, right? That looks like a hip replacement. So somewhere along the line, orthopedic surgeons, right, thinking, well, if the shoulder is the homologous joint to the hip, we can just design a hip replacement and put it in there. I have no idea, this is the Stanmore implant, how they could get this into the glenoid down here, all right? But they did, right? Didn't work very well, but they got it in, right? This is, anybody know what this one is, right? This is the so-called Michael Reese shoulder. Michael Reese was a hospital in Chicago. Mel Post designed this. The problem was there was a Michael Reese 1, there was a Michael Reese 2, and the Michael Reese 3. Right? By that time they think they got it right, but they really didn't get it right. These are some of Neer's original implants. Right? To address the problem of rotator cuff deficiency, basically he had a hooded glenoid to prevent superior migration. Before we recognized that superior migration occurred, it put eccentric loads on the glenoid, and the glenoid would fail. So these were the earlier designs. Then we saw these, metal backing on the glenoid. If metal backing worked around the hip, and it was so important for the hip, as Indong Oh showed in some of his early studies, let's put it around the glenoid. Well, the fact is it doesn't work around the glenoid. You have to thin the polyethylene too much, and it doesn't have the same impact with respect to the cement bone stresses. Then some non-cemented implants from Bob Cofield, and then ultimately some degree of modularity that occurred, right, to allow the goal of reproducing the anatomy of the proximal humerus. And that's the most important aspect of prosthetic design for anatomic shoulder replacements. Reproducing the anatomy. The ability to reproduce the anatomy is probably the most important goal. So, but when it all comes down to, I think I skipped a slide, no. When it all comes down to, there are two broad categories of implants that are out there now. The first is the anatomic replacement, a non-constrained, shown here, in which you have a humeral component with a polyethylene or some other type of glenoid component for patients that have pathology in which the rotator cuff is intact or functions, right? And then the other broad category is fixed fulcrum designs, or the so-called reverse shoulder arthroplasties. That are designed for patients that have incompetence of the rotator cuff or some other condition that is an indication for a reverse shoulder arthroplasty. And I'll talk about that as we go along. But these are the two broad categories, and there are multiple variations in each of these categories that are out there. Now, when you think about non-constrained designs, this is where reproducing anatomy is important. We know that a monoblock prosthesis for the humerus doesn't reproduce the anatomy. The humeral head is offset from the longitudinal axis of the humerus in a posterior and medial position. A single piece prosthesis can't do that. A modular humeral head on a central portion that's not eccentric can't reproduce the anatomy. So if you're doing shoulder arthroplasty in 2014, you want to use an implant that allows you to reproduce offset, reproduce eccentricity of the proximal humerus, achieve metaphyseal coverage, right? And in relation to the glenoid, achieve some radial mismatch, because the radius of curvature of the humeral head is different than the radius of curvature of the glenoid. That's what allows translation to occur, and translation is necessary to achieve range of motion afterwards. So modularity is important, and how you achieve that, it could be any one of a number of 20, 30, or 40 different designs. The basic concept of the fixed fulcrum is the moving the center of rotation to the glenoid itself. By medializing the center of rotation, it makes the deltoid more efficient. You lengthen the deltoid by placing the humeral implant more distally and laterally, and the glenoid fixation is usually less of an issue because you've got a variation on this design or other designs that allow you to put the glenoid component in place. Now, so let me tell you a little story, right? So in 1988, my chief at that time, Victor Frankl, who probably nobody's ever heard of except maybe you guys, right? Okay. He came back from France, and I was 4 years on the faculty there, and he said to me, Joe, I just saw this prosthesis by Paul Gramont in Dijon, France, all right, and I think you should go look at it. It's very interesting. So back in 1988, right, if your chief told you to do something, you just did it. Does that resonate at all with you? All right? No. Yeah, 1988, right? So even though I had like a 2-year-old at home, all right, 2 weeks later, I'm on a plane to Dijon, France, right, which up to that point I thought was just mustard, right? So, and I fly into there, and I have to tell you, Paul Gramont didn't know me from anywhere. He was incredibly gracious for the 2 or 3 days that I was there. I watched him operate. We had meals together. He was incredibly gracious. And I saw him using his reverse shoulder prosthesis. The problem was I saw him using it in patients that had straightforward osteoarthritis, in which he would just resect the rotator cuff. And I saw some other weird things when I was there. He was doing glenoid osteotomies for people with massive rotator cuff repairs, which just didn't make a sense. I'm 4 years in practice, and I'm trying to do things the way I was taught. So I came back, and Victor said, what do you think? And I said to him, I saw it. Paul Gramont, he's a nice guy, but I don't think this is going anywhere. Now, that's, little did I know, all right, that's for sure, all right. Certainly it's gone somewhere, but the interesting thing is not the implant at that time and not how he was using it. It took a number of years afterwards, with particularly with the help of guys like Gilles Wash and Pascal Boileau, to help design it and get it to where it is today, particularly with respect to indications. But that was my earliest exposure to it, and I didn't jump on the bandwagon when maybe I should have. So, reverses. This is a partial list of the reverses that are out there on the market. Same basic concept. You can use, different type of screw configurations, trabecular metal, longer stem, fatter stem, shorter stem, no stem, all right? All these things are out there. The same basic idea remains true. These are fixed fulcrum. Some medialize the center of rotation. Mark Frankel's prosthesis, the Encore, lateralizes the center of rotation, all right? There's a whole different variation. The important thing is to recognize, when it should be used and how to use it, because each one will vary. Then you get some of these other prosthetic options that are out there. The so-called cuff tear arthropathy head. good idea. Somebody thought of it. If the humerus rides proximally and you get contact between the graded tuberosity and the acromion, well, let's just put a flange on this so it's metal against metal as opposed to bone against metal against bone rather than the bone against bone. Makes sense. However, to my knowledge, there is no report in the literature that shows a benefit of this implant over a standard proximal humeral replacement. Nonetheless, it was out there for a number of years and being used in patients with rotator cuff arthropathy. Humeral head resurfacing, there's probably a role for that. Is there a role for this when you're replacing the glenoid component? Not in my hands, right? Because I think the most important part of a shoulder replacement is how you put the glenoid in. And if I don't resect the humeral head, I can't get the glenoid in with the degree of certainty and positioning that I want to. But nonetheless, Steve Copeland in England has made a career out of it. He's reported hundreds and hundreds of total shoulder replacements in which the humeral side is resurfaced and not replaced. And then you get something like this limited resurfacing, for focal lesions of the humeral head. So there's a place for these. I'm not sure where it is. It's not so well defined, and it really becomes a matter of, well, when I'm in the operating room with my residents and we talk, I'm doing this operation with them, I say there are things that you do in the operating room that are either BSF, which is based in scientific fact, in which there's really some measure of evidence that says this is how we should do it, all right? This works. And then there's the rest of the stuff, which is kind of PP, personal preference, all right? This is the way I like to do it because I'm used to it, I'm comfortable with it, right? A lot of this stuff is based on personal preference. If you think this works better than another implant, you use it. If you think this works, then you use it. There's not a whole lot of evidence out there that supports its use. So we come back to the equation. You have a patient, a disease process, all these implants, and you got to develop a treatment plan. So let's look at a partial list of the different types of glenohumeral arthritis that is out there. Regardless of the arthritis, right, the indications for prosthetic replacement remain the same, right? Severe pain, restricted range of motion, difficulty performing activities of daily living with x-rays that show advanced glenohumeral arthritis. Now I put a question mark after that because as you'll see, we're doing shoulder arthroplasty in patients with not a whole lot of advanced arthritis and maybe not any arthritis at all, but we'll talk about that as we go on. But this one's important. Failed non-operative management. My practice, I only do 3 operations at this time in my practice. I do shoulder arthroplasty or revisions thereof, and I do hip replacement and knee replacement. If you take 10 patients who come into my office with arthritis of the hip or arthritis of the knee, I'm operating on 8 of them. You take 10 patients with glenohumeral arthritis, I'm operating on 2 or 3 of them. This is a much more forgiving condition. It's forgiving for 2 reasons. The obvious one, it's not a weight-bearing joint like the lower extremity. The more significant one is, if I've got a bad shoulder, I can compensate with this. If I've got a bad hip, I can't compensate with the other side. I need 2 legs to walk. So it becomes much more of a non-disabling condition for the shoulder than it is for the hip or the knee, which is why I think we tend to do less of them for the patients that actually have glenohumeral arthritis. Who don't you operate on? The usual patients. Neuropathic arthropathy, septic arthritis active. I've done many cases in patients that have had septic arthritis previously. You worry about it, you have to work them up extensively, right, and take certain precautions ahead of time, and you can usually effectively treat them and avoid a recurrence of the infection. And patients who have both deltoid and rotator cuff paralysis or absence, destruction of those muscles together, they don't have a whole lot of options, that's for sure. So let's look at osteoarthritis. So the clinical manifestations of patients with osteoarthritis of the glenohumeral joint are, these are older patients. Males are more common than females. This tends to be classically a monoarticular condition. They tend to have an internal rotation contraction, in part because they may have posterior erosion of the glenoid and posterior subluxation. And the rotator cuff is uncommonly involved with maybe less than 5% with a full thickness tear. Now, keep in mind, I'm going to talk about osteoarthritis, I'm going to talk about rheumatoid arthritis. When I was going through medical school or residency, people made you think that the world of arthritis was divided into osteoarthritis and rheumatoid arthritis. And if these were Venn diagrams, you'd have a circle of people with osteoarthritis and a circle of people with rheumatoid arthritis, and they didn't overlap. That's not the case. These Venn diagrams overlap. I don't call it rheumatoid arthritis anymore, I call it inflammatory arthritis. The classic patients with osteoarthritis, I think, is uncommon. When I do bilateral hips, knees, and shoulders in somebody with osteoarthritis, right? That's not osteoarthritis. That's a systemic condition somehow that predisposes them to arthritis that the rheumatologist can't yet identify, right? So there's an inflammatory component, to me, a systemic component of a lot of patients we've classically called osteoarthritis. So there is a lot of overlap. So there's not separate populations. There's a continuum that takes place in patients with arthritis, from non-inflammatory to inflammatory. That's just my little soapbox opinion about it. Now, patients radiographically with osteoarthritis, subchondral sclerosis, not much different than around the hips or knees. The glenoid can be enlarged as a result of osteophyte formation about the periphery, but you'll see it much more commonly on the humeral side. Large inferior humeral head osteophytes can be commonplace. There's asymmetric glenoid wear, and this has been classified as the type A, B, and C. C, with increasing glenoid erosion and retroversion, you progress through A, B, and C. This would be called a biconcave glenoid because there's concavity here and concavity here, with this sitting posteriorly. And you really have to focus on glenoid erosion. There was a time in my career that I would try and determine glenoid anatomy based upon a good axillary view. And I found that I was being fooled, that I couldn't correlate the axillary view with the intraoperative findings. So then I started getting CAT scans in some patients, right? And that helped. Now I get CAT scans in every patient I operate on, who I'm going to operate on for glenohumeral arthritis. Just yesterday I had a meeting with our radiologist, and they brought me from the 3D printer, right, a model of patients that they got a CT scan on. They're now giving me a scapula with the glenoid, right, basically in my hand, that I can look at it. And they gave it to me for 2 cases that I had just done the previous week, right, and it was incredibly accurate. Somebody with extensive glenoid osteophytes, basically, I would have understood a lot better if I had this model ahead of time, because even translating the CT scan into a 3-dimensional model, even with the reconstructions they do, is different than holding it in your hand. Right? We get a lot more out of the tactile feeling than we do. So I think that's going to have some promise. That's for sure. So patients with osteoarthritis here, this is an osteoarthritic patient. A non-constrained replacement is appropriate. You look at this patient here, also looks like osteoarthritis, right? But here's the importance of getting the proper X-rays. You see this here. You say a worn out joint. You see this here, it's a scapular Y view, and you say, well, you can't see much. But if you look at this more closely, here's the Y, right here. Here's the head, right? The head is clearly sitting posteriorly, right? That's why you get an axillary view, which is the X-ray I showed you before. It's sitting all the way posteriorly. Now, when I did this case 15, 18 years ago, I did a hemiarthroplasty, and I flattened out the glenoid, trying to basically achieve some concavity, and we did a hemiarthroplasty. Now, in 2014, I'd probably do a reverse if this patient was appropriate age and activity level. Because that degree of glenoid deformity, I think you can do a reverse because the glenoid fixation is more forgiving on the glenoid side. So let's look at rheumatoid arthritis. And I call it rheumatoid arthritis, but the classic seropositive rheumatoid arthritis patients you don't see as frequently as the population of patients with inflammatory arthritis. These are generally younger because it's a disease process that starts earlier in life. Females more than males, and it's a polyarticular disease with systemic manifestations. These patients can be sick. They can have, splenic problems, visual problems, a whole host of immune compromise. However, the polyarticular nature of it means 2 things. Number 1, if you've got a bad hip or knee and a bad shoulder, what are you going to do first? What are you doing? You doing the hip or the shoulder? Somebody say something. Hip. You're doing the hip, right? Because I don't want my patients walking around with crutches, right, after I put a shoulder replacement in them if I can avoid it. On the other hand, right, generally patients will want their hips done first because it's much more disabling. Now, suppose you've got a patient with ipsilateral shoulder and elbow or hand arthritis. Well, that's a different staging process for that. That you have to think about. In general, you always do the more symptomatic joint first. However, keep in mind, when you progress from the shoulder to the elbow to the hand, the shoulder and the elbow position the hand in space, right? If you can position the hand in space, but the hand can't do anything because of MCP subluxations or significant deformity, you better do something with the hand first to make it more functional. So the staging of an upper extremity is different than the staging between the upper and the lower extremity. But the other thing to point out is rotator cuff compromise, because this is a collagen-based disease, is frequent. So you may have the rotator cuff intact, but significantly worn or thinned, and even if it's intact, it may not be functional. And I've underestimated the impact of rotator cuff disease in patients with inflammatory arthritis doing an anatomic replacement only to be disappointed in the range of motion that they get afterwards. Now, this is that x-ray I showed you before, which you don't usually see. You don't see this much anymore either. These are the rice bodies that you'll see when you open up the subacromial subdeltoid bursa in patients with inflammatory arthritis. You don't see this much because of the different treatment modalities and disease-modifying agents that we have that we didn't have before. One thing I'll point out, the acromioclavicular joint is a diarthrodial joint. It's a synovial joint, just like the glenohumeral joint. You know, I've had a few patients through the years, you do a shoulder arthroplasty, and they only come back complaining of pain at the AC joint because I overlooked the contribution of the AC joint as part of the inflammatory process. So in this particular patient, there's no choice, right? You had to do a hemiarthroplasty because there's just no glenoid there. And we'll talk about the glenoid later on. Now, post-traumatic arthritis is a whole different deal. Every patient with post-traumatic arthritis is different than the next one you're going to see or the one you saw before. These generally are older patients, females more than males, probably because this is proximal humeral fractures is a condition of, it is an osteoporotic-based fracture. It occurs more commonly in females, in metaphyseal bone, and more commonly over the age or after the 5th decade. If they've had surgery, scarring is significant. Even if they haven't had surgery, there's significant scarring. The degree of bony deformity is important, and you really have to understand this to represent it, and don't underestimate the significance of an unrecognized, the possibility of an unrecognized neurologic injury. So you can get x-rays like this. And again, it shows if you've seen one, you've seen one, right? This is a different deal, right, compared to this, right, which presents other things. Tuberosity malunion is a significant problem, right, particularly the greater tuberosity, and I'll talk about that in the next couple of slides. Articular incongruity can more easily be addressed because you're going to resurface it. The presence of hardware. Usually this is humeral-based disease, right? It's not the glenoid, so the glenoid can be much more forgiving in this. However, I have a low threshold to replace the glenoid in post-traumatic arthritis because I think the glenoid is involved and there's a tendency to underestimate it. Now, when you treat patients with post-traumatic arthritis, what are you looking for? Well, there's been some studies out there that have shown if you can correct the osseous and soft tissue abnormalities, then you can have a good outcome. All right? I mean, you know, that makes sense, all right? It's one of those intrinsic things. If you can correct what's wrong with it, they're going to do better. Okay, I know that. However, if you have to do a greater tuberosity osteotomy to realign it, that is correlated with a negative outcome. Now, do I know that to be true? Of course I know it to be true, because through the years, I've done post-traumatic arthritis, and I've done greater tuberosity osteotomies to get a great look in x-rays post-op and to have that tuberosity migrate, you know, post-operatively. Right, within the first 3 weeks, 6 weeks, or 3 months, right? So much so that when I do post-traumatic arthritis now, I do whatever I can to avoid a greater tuberosity osteotomy. I'm much less concerned about the lesser or the subscapularis, but the greater, I'm going to try and avoid it, particularly for anatomic replacements. Reverse is a different deal. So I'm accepting some degree of residual deformity of the greater tuberosity or even the humeral shaft in an effort to avoid osteotomies. So in this particular case, you can see that this is the greater tuberosity is superior and posterior, and basically I whittled it down and put the stem in varus, right, to avoid, you know, having to do any kind of osteotomy, right, and made sure that the rotator cuff would still be intact, right. This one you can't work around it. The degree of deformity is too significant. This does require an osteotomy, but not just of the greater tuberosity. It requires an osteotomy of the humeral neck to basically put the ice cream, you know, back on the cone, so to speak, right? Which is what we did in this particular case. And since this was a younger patient, did not need a glenoid resurfacing, at least at that point. Another example of post-traumatic arthritis with hardware in place, significant osteonecrosis with secondary glenoid changes. Tuberosity is posterior. But my experience with these is that when you see an x-ray like this, the degree of bony involvement is obvious. The degree of soft tissue involvement is much underestimated. So for me, it's rare for me not to try and utilize the reverse when I do this because I think the rotator cuff is not going to work afterwards, and that's what we did here. Now, when you've got post-traumatic arthritis with the articular cartilage changes, basically the books will tell you if the glenoid is not involved, don't replace the humerus. As I said before, my predisposition is to replace the humerus in almost every case. It's the exception for me rather than the rule not to replace not to replace the glenoid, right? Because I just think it's a source of problems afterwards, and patients do better with resurfacing of both sides, a total shoulder arthroplasty, than they do with a hemiarthroplasty. So in this particular case, a broad example of example of osteonecrosis, not a lot of proximal humeral deformity, but certainly significant collapse, as you can see here, without a lot of with the glenoid secondarily involved, but the rotator cuff okay. This one got an anatomic. Now, osteonecrosis. Let's just talk about that a little bit. Osteonecrosis occurs for a reason. Occasionally, we'll see patients that have so-called idiopathic osteonecrosis, but it's your responsibility to look as closely as possible to identify a source. And the sources that you need to, or the factors associated with it, obviously steroid use, alcohol use, post-traumatic, lupus, other conditions, because that affects the management of the patient. Somebody that has lupus is different than operating on somebody with post-traumatic arthritis with osteonecrosis. So you need to know that. If it's secondary to steroid use, they may have multiple sites involved. So this is the concept of understanding the patient that you're treating. What you see radiographically can vary from stage 0 or stage 1 or 2 with no collapse versus this one, which is hard to believe that this is actually osteonecrosis. This patient got sent to me after being biopsied for a tumor, right? Because they thought this was some bone destructive process, which is frankly perfectly reasonable from my point of view. This is a humeral-sided condition. However, don't underestimate the inflammatory response that I think takes place within the joint as this process unfolds. Even so, in some cases, I'll avoid the glenoid, but in most cases, I'm still going to resurface the glenoid. Now, you see, I put this in here just to be complete. This is the limited humeral head resurfacing that I showed earlier on. I took this off the website for the company because I'd never done one of these cases. Now, why haven't I done one of these cases? I don't think it offers anything, right? And the second thing is that, at least in our institution, they were charging us $5,000 for this little piece of metal, right? And we are very focused on costs, all right? So it seemed completely ridiculous to me to pay that amount of money for this. So until they dropped the prices to about $75, we weren't going to do it, all right? So, which I obviously I'm being facetious, all right? But you have to think about that before you just throw one of these things in, because that's a ridiculous amount of money, right, for this implant that has no track record of clinical efficacy. So people will say, well, this is a bone-preserving operation, and I can't disagree with that. People will say a humeral head resurfacing is a bone-preserving operation. People will say the short stem humeral components is a bone-preserving operation. I can't disagree with that. I just don't think preserving bone of the proximal humerus is all that important, right? So my go-to operation basically is on the humeral side is a humeral replacement, right? Occasionally a resurfacing, right, in an unusual circumstance, but I just use a straightforward hemiarthroplasty because I think they're reliable and they work. So here's an example, osteonecrosis without glenoid involvement. We did this. Now, why did I do this operation a number of years ago? I needed the slide. Right. All right. I had to put this talk together. Right. I needed this slide, so I had to do a couple of these. All right. Now this is more significant with secondary glenoid changes. You can do an anatomic replacement in this. Now let's talk about rotator cuff arthropathy, since this seems to get a whole lot of emphasis these days. The true rotator cuff arthropathy patient, and if you look through the rheumatology literature, there's something called Milwaukee shoulder. Described by Daniel McCarty, who was the chief of rheumatology at the Medical College of Wisconsin. What he's describing and what Neer described is basically the same thing, right? What Neer truly described. If you go back to Neer's original article, he described a specific entity which is much different than what we're calling rotator cuff arthropathy now. And it really looked like it was an inflammatory process. So you'll see patients with so-called rotator cuff arthropathy. They may have had previous surgery. They've got rotator cuff atrophy. They'll oftentimes have this large fluid accumulation evident because the glenohumeral joint is producing synovial fluid and it's uncontained, so it basically escapes into the subdeltoid and subacromial bursa and fills up the shoulder. You see anterior superior escape and the so-called pseudoparalysis, when you say lift your arm and they go like this. because they get this unrestrained upward pull of the deltoid without the downward force couple effect of the rotator cuff. That's the classic example. However, many patients with rotator cuff arthropathy, right, can raise their arm very nicely, but it's painful. Those are more challenging cases. So you see something like this, right? Superior migration, glenohumeral arthritis. You know, this, everybody would agree this is rotator cuff arthropathy. However, in 2014, right, when people talk about rotator cuff arthropathy, a lot of things get labeled under that. And I think there are 3 specific scenarios that fall under the category of what we're calling rotator cuff arthropathy, not what Neer called it originally or what McCarty described. And these are the 3. I want to talk about each one. So the first one is true rotator cuff arthropathy, basically with a variable bone loss. You've got degenerative changes about the glenoid, the humeral head, the acromion, things like this, right? Things like this, significant superior migration and secondary changes. That's close, right? The x-ray I showed you before. This is the true rotator cuff in which the arthritis is a predominant finding in association with a massive rotator cuff defect. So something like this, you know, the treatment for this is a reverse. That's nothing mysterious about this. In the old days, we did hemiarthroplasties, and I have a series of about 20 cases reported in the Journal of Shoulder and Elbow Surgery, in which on a limited goals category, we had about, 60 or 70% success afterwards. This is clearly a much better operation than a hemiarthroplasty, that's for sure. So what about this, all right? Now, look at the amount of glenoid erosion. When you see the humerus medial to the edge of the acromion like this, you know you've got significant glenoid erosion, right? So is there enough glenoid there to put in a glenoid or not? Well, I thought there was, all right, because I will always stretch the glenoid. Now, look at the second one. Basically, the second situation is when you have rotator cuff deficient shoulder in which the degree of arthritis you see on x-ray is really kind of secondary. They're not coming to you because they've got pain predominantly from the arthritis. They're coming to you because they've got pain and limitation of motion from the rotator cuff deficiency. And they can't lift their arm because of the rotator cuff deficiency, but they've got some degree of arthritis too. I mean, something, to me, this is more of a rotator cuff problem than an arthritis problem, or that one too, but the arthritis is there as well. So this is kind of the middle ground between true rotator cuff arthropathy and the true rotator cuff deficient shoulder without arthritis. So listen, you just have to recognize what this is, because the treatment's going to be the same. I mean, that's, the reverse is out there, and that's what you're going to do for patients that have this. Now, the third category that gets called rotator cuff arthropathy, which really isn't, is the patient with a massive rotator cuff tear. Someone has had 2 or 3 repairs. They have an MRI shows absence and retraction of the supraspinatus, the infraspinatus. Maybe there's part of the subscapularis still present, but the rotator cuff problem is the problem. And they may have no arthritis whatsoever, but they can't lift their arm up like this, right? That's not rotator cuff arthropathy, truly, but it is, because the treatment for this is going to be basically a reverse. And as we've gotten more comfortable with reverses, we've expanded the indications. So somebody comes into my office now, frankly, a 52-year-old who's had 3 rotator cuff repairs, can't lift their arm over 80 degrees, terrible pain, x-ray shows superior migration, but the absence of arthritis, 52 years old, I hesitate a little bit, but he's getting the reverse. All right, as long as they understand, right, what the implications and limitations are going forward, because that's the best way I can treat this. I've done latissimus dorsi transfers, right? I've done hemiarthroplasty. I've done all these things. It doesn't work near as well as a reverse, as you'd see in this lady. All right, 3 rotator cuff repairs, all right, miserable, right, and this is what she gets. Now, there's a lot there in the literature that says, in what conditions do you replace the humeral head alone, and in what conditions do you replace the humeral head and the glenoid? I think Charlie Rockwood, I know he's from Texas, did us a disservice when he published these articles that said, if you have osteoarthritis, you do just as well with a hemiarthroplasty as you do if you do a glenoid, all right? And he showed, they had some series of patients that showed there was no statistically significant difference in the outcomes, all right? But if you've ever taken care of a patient with a hemiarthroplasty versus a total shoulder replacement for osteoarthritis, at least the ones in New York, all right, Texas may be different, right? They are not near as happy as this. They don't get the same pain relief. They don't get the same function. So from my point of view, this gets me back to my my preference is, which is replacing the glenoid. Now, why wouldn't somebody replace the glenoid? I'll tell you why you don't replace the glenoid. In theory, because they say, well, it's the weak link. The fixation of the glenoid becomes a problem in the long term, and you worry about loosening, et cetera. Well, you worry about radiolucent lines. Loosening is a whole different deal and not an issue. But the other reason I think people avoid the glenoid is because it's the hardest part of the operation. Getting the glenoid exposed, putting it in properly, that's a hard part of the operation, all right? So I don't disagree with that, but to me, it's a necessary part of the operation. So this is one of those that is based upon personal opinion, right, as opposed to what I think is the science. I think the science really shows the weight of evidence is in favor of resurfacing the glenoid, particularly in patients with osteoarthritis. Now, let's talk about this hemiarthroplasty versus total shoulder replacement. So sometimes you can't put it in because there's too much glenoid bone loss. Sometimes it's not necessary, like we talked about before, with absolutely pristine glenoid, maybe in a younger patient with osteonecrosis. So in that case, you can avoid the glenoid, right? But from my point of view, I have, as I pointed out 4 times already, I have a very low threshold to insert the glenoid because I think patients do better. I particularly have a low threshold with it now because I think that we have a type of glenoid component which long-term fixation is not going to be the issue that it was before. So here's an example. Now, a lot of glenoid erosion. The humeral head is medial to the acromion. This amount of glenoid wear. Now, there's no way that I can put a glenoid component in this for an anatomic replacement, even if the rotator cuff is intact. Now, the rotator cuff was intact, but with this significant medialization and contracture, even if I could put a glenoid in, an anatomic replacement, it's not going to work. The rotator cuff is never going to work afterwards such that they get some function. So this is already a reverse for me. The question is, can you put a reverse in somebody like this? Well, you can. You have to do things, right, to something like this. You got to bone graft the glenoid. You have to lateralize it, right, put the glenoid from the bone from the humeral head on the back of the glenoid, put it in here. You can see the graft right here to basically reestablish the glenoid. Now, this is an operation that seems to work. The bone seems to get supported, but I don't have 5 or 6 year follow-up that really shows incorporation or resorption. This is an operation that I've done a number of times, but I'm doing less and less. I'm doing less and less of it because it's going by way of the progression that's taken place in total knee replacement or total hip replacement. You've got, in the old days, when we used to have significant superior acetabular wear or significant medial erosion of the glenoid, what would we do? We'd bone graft it. We'd take bone from the femoral head or bone from the femoral resection, and we reestablish the bony support and put the implant in. Those didn't work all that well. So what do we do now around the knee? Replace it with metal, right? You got all these wedges, right? Blocks and everything else because it works better. Around the hip, augments, right? It works better. It's more reliable. Do the same thing here. You can, by using augmented glenoids that either are thicker and lateralize it or are built up posteriorly or superiorly, you can achieve the same thing rather than adding bone graft to it, because I think in the long term you're probably better off with metal, but that remains to be seen. Now, some people would say that in young patients, you don't want to put a glenoid in because of concerns about loosening. I understand that, but to me that gets to be a fixation issue. Again, I have a low threshold for insertion of a glenoid component. So this is somebody that had a shoulder instability surgery with these anchors in place that developed significant arthritis in a 28-year-old. Are you going to do a replacement in a 28-year-old? Most people who do a hemiarthroplasty, even in these young patients, I've been doing shoulder replacements, all right, and resurfacing the glenoid. But to me, this is an implant that we now have in our system, which basically achieves, we think, maximum ingrowth through this plate. The peripheral pegs are cemented, but the fixation is really the central peg. It's almost like the global shoulder, where they've got that magic peg centrally. That's a polyethylene peg. This is a metal one that gives you good interference fit fixation. And we've got CT scans postoperatively in selected patients that show bone through growth through this central cage, right, which we think provides good fixation. So I'm much more, I'm much happier now since I think I've got a device, a glenoid that is in it for the long term. So when you come down to the question of anatomic replacement versus a reverse, right? Well, so who are we doing reverses in? Well, let's summarize what we talked about. Severe rotator cuff dysfunction, the so-called irreparable rotator cuff tear, absence of the rotator cuff, patient with arthritis or even without arthritis. The guy had adequate glenoid bone stock, but that's a relative term. You see what we did with the bone grafting there, because you can put a glenoid in with a reverse more easily than an anatomic with one provision. So I saw a patient, and I should put this patient's slides in here, but maybe I'll do that for the next time I put this together. A patient had a reverse shoulder replacement, I don't know, maybe 7 or 8 years ago. I didn't do this one. She's a rheumatoid, and basically she had glenoid deficiency, and she fractured the base of the glenoid, right, off. So now she's got the glenoid component and the glenoid now floating. I followed her for the last 4 years, right? She was uncomfortable but reasonable, and I followed her now, and she has some pain. It increases at times, but you'll see on X-ray she's basically eroded more medially, right? She's actually eroded the lateral third of her clavicle. Now, there are certain structures, right, underneath the clavicle that we go into orthopedics so we can never have to see ever again, right? So she worries me, all right? So I got a CAT scan trying to look. I want to make sure she doesn't erode into something. So I actually had our chief of thoracic surgery look at all these imaging studies, and he thinks she's far away from any vessels. So we're just going to follow her. Of course, she's 84, and she doesn't really use the arm that much. But that's a problem. If the glenoid fails by fracturing because you don't have enough bone, to me, that's an unreconstructable problem around it. And if I was to take that out, she'd be left with just a hemiarthroplasty, with a big humeral head, just to try and give her some support. So you're going to do a reverse when they have an intact deltoid with indications, I think, that are now evolving, right? So there's a reason why we're doing so many reverses, because now if I do an 84-year-old or a 78-year-old with a rotator cuff intact but degenerated, I'm more likely to do a reverse in that person rather than anatomic, because I think they're going to do better in the long term. Because the rotator cuff continues to deteriorate as you get older. And as I said before, I've underestimated the ability of the rotator cuff to function and recover from the surgery that we perform when you're retracting the rotator cuff to get to the humerus, and you're really kind of damaging it, even though we like to think to a limited extent. When they have certain comorbidities, I'm doing reverses, and the examples of those are Parkinson's. I've got a nice little series of patients with Parkinson's disease who I've done anatomic shoulder replacements in who did lousy, all right? Terrible outcomes, right? The constant rigidity that they have, it just stresses it. They can't move their shoulders. The rotator cuff fails. It's a bad operation in patients with Parkinson's disease. I don't do that anymore. They get reverses. If there's significant glenoid erosion, as I pointed out before, I don't try and put I don't bone graft the glenoid anymore, all right? I will not do a hemiarthroplasty. I'll more likely go to a reverse. And if they've got post-traumatic arthritis with significant humeral deformity, this is a much more forgiving operation for the humeral side, as well as treating acute, complex proximal humeral fractures with reverses. So there's a reason why in 2013, the number of reverse shoulder arthroplasties exceeded the number of anatomic shoulder arthroplasties in this country. Now think about that. For something that wasn't even on the scene 10 years ago, we're doing more reverses now than we are anatomics, for two reasons. The indications for a primary reverse have expanded, and for failed arthroplasty, what's the salvage procedure or or failed hemiarthroplasty? It's a reverse, right? When you factor those into it, it makes sense that we're doing more than the anatomic. So it gets back. You've seen this slide before, all right? The whole purpose of this talk was to emphasize that for the treatment of glenohumeral arthritis, this applies. It applies just like any other condition in orthopedics. You have to understand the patient, understand the disease process of the condition that's led to the glenohumeral arthritis, and then understand the options that are available and determine your treatment plan. It works every time, right? If you pay attention to it, and if it works around the shoulder, it's going to work in virtually every other area for patients that you treat. So with that, I'll stop. Thanks.
Thank you. So the floor is open for questions. Yes, Dan.
Thank you for that talk.
Do you really mean that, or are you just saying that? All right, are you sure? I mean, are you saying it with feeling? Okay, because most of the time they say, "Well, thank you for that talk," right? Or they say, "Thank you for that talk. I have a question." Okay.
So you did mention that.
By the way, thank you for this question. Okay.
You did mention that you're going away from using bone stock as your bone graft, or bone graft as your lateralized. Does that mean that there's a mark or I guess a product out there for glenoid specific augments? I haven't seen
Yeah, even if you do an anatomic replacement, there are augmented glenoids now.
Are there?
Yeah, there are augmented glenoids in the system that we designed. DePuy has step-cut glenoids that can replace it as well. I mean, I did this most recent, the last bone graft I did was bone from the humeral head. We made a step cut in the glenoid, put this glenoid in. My associate helped me with it. We had this arthroscopic cannula from behind, so we put screws in to the bone graft posteriorly, then put a glenoid in. It was a great looking X-ray, all right? And then the bone graft resorbed, all right? And no, we did a hemiarthroplasty and with a bone graft, right? But we didn't resurface the glenoid, right, because of her age. And it looked great. Then it resorbs, and now we got a prominent screw. So now I have to go back and revise it. I'm going to put a glenoid in, all right? And one of the screw heads was stripped. Now I can't get the screw out of the glenoid. So I have to modify the glenoid component, right, you know, with the peg so I can work around the screw that's still in the glenoid, all right? I'm not doing that anymore, all right, okay? So I agree, you use augmented glenoids. And you can use it for anatomics or reverses.
And just a follow-up, has there been any series? I haven't seen any literature on the metal augment.
No, not yet. Not yet. They will be out there. However, have you seen any series on glenoid bone grafting for anatomics? There's about 2 out there.
Yeah,
There's 2. There was Neer's original series that he reported, like 10 or 12. Interestingly, there were no X-rays, postoperative X-rays in that report, all right? Because I don't think he had anything good to show. And I think Tom Norris had one as well for anatomics, which is a small series. There's not a whole lot out there about that either. Yes, sir. No.
What's the youngest patient you put in the reverse in, and what do you think is the longevity of a primary reverse shoulder?
Okay, so the youngest patient I put a reverse in is probably 48, all right? And that was for a failed arthroplasty, right? Would I do it in a younger patient? Yes, all right, I would. 5 years ago, I wouldn't have, right? But as we increase our experience and comfort level, I think it's a reasonable thing to do. And it's a little bit like hip replacements. I still see patients in my office who are 52 years old, and they've been told by an orthopedist that you're too young for a hip replacement. Would you do a hip replacement in somebody that's 52?
Yeah.
Would you do a hip replacement in somebody that's 28?
48? 28. 28? I think twice, but yeah.
You think twice, but you do it because if to me, and I think about myself, if I was 28 and I had a disabling hip condition, right, then I couldn't have any quality of life. Not to go skiing and to play, rugby or skydive, right? But and I knew it was going to give me 10 years of quality of life, and then I have to deal with some revision, sign me up. All right, that 10 years is important. I think the same thing can apply to patients that have disabling shoulder problems that really adversely affect their quality of life. They need to understand this may not be the last one, right? But I also think that glenoid fixation, which is the problem with anatomic shoulder replacements, may prove to be less of a problem with reverses. May.
How long do they last?
You know something? If you look at, it's like anything else. We don't have enough data on what we're currently using now. The Kaplan-Meier survivals, right, tend to follow two patterns. If you don't have a complication like infection or instability, right, then the numbers are pretty good, getting out to 8 or 10 years, like 90%, right? But those were those implants, and now we have these implants. If you look at the Charnley survival after total hips, it tells you one thing, but we don't use Charnleys anymore. So do we have enough information about the current state-of-the-art non-cemented hip replacements? So it's a guess, right? And patients have to understand that. But we live in a society now where quality of life and immediate gratification is a big part of things, right? Which doesn't mean we do whatever patients want us to do, but I think it's reasonable to offer as an option as long as they understand. Okay.
I'm really intrigued by your glenoid component with the hollow stem that permits bone to grow apart. What's been your experience? How many have you done? What's the longevity?
Yeah, so of the people that are using it, we've only been using it for 2 years, all right? So we don't have any long-term follow-up. And I've got 3 or 4 patients in which I've got CAT scans to specifically look at it. And the ingrowth is there, there's no doubt about it. Whether it's going to be for the long term remains to be seen. But it's the same design as the reverse implant. The reverse implant is longer, right? But it's the same bone through growth. We fill it up with bone before we put it in, and so far it looks like it's to be working.
CT scan.
Yeah, CT scans that shows 6 months afterwards. Again, these are just a few patients.
Sure.
I like it for another reason, because the to me, the worst part of an anatomic shoulder replacement is after I put the glenoid in and I've got to hold it there while the cement hardens. Right? Now, I usually don't do that. I have the resident do it or the fellow do it, and I usually go do something else. Right? So it's such a boring part of the operation. Right? So when you put this in, it's an interference fit. So basically, you move on to the next part of the operation. Even though you cemented to peripheral pegs, right? I don't have any issue about not holding it. It's in, and we go on. So it saves you about 10 minutes during the operation.
Also, could you take a second and maybe speak to the patient that's not a candidate for traditional total shoulder or reverse? Let's say someone who's had chronic sepsis. What's the treatment for them? Is fusion a consideration?
Yeah. So,
and if so, how do you perform that?
Yeah. So I think I've done 5 fusions or 6 fusions in 30 years. All right, and they've all been in patients with sepsis or uncontrolled sepsis or post-septic arthritis with significant soft tissue destruction, deltoids off, acromions off, and such. And those patients are so disabled that a fusion is a good thing because invariably they're on the younger side. I've not done any fusions after failed arthroplasty, which you know is a whole complex operation because you got to do probably a vascularized fibula or something like that. When they're so disabled, I think that's the best option, right? But it's not a simple slam dunk operation, all right? I'll tell you this one other story. So I had 20 years ago, I had a patient who had a hang gliding accident. So she had basically, knocked off her whole brachial plexus. She had, a dead arm. She had a little bit of scapular function, right, but nothing down here, phantom limb pain. She came to me wanting her arm cut off, right? She wanted an amputation. So we went through the whole thing, psychologist, the whole thing. And I decided, since she had no shoulder function, to give her a prosthesis. We were going to fuse her shoulder. All right, so she could have a stable support here, which she could wear an implant. So when you think about the incidence of non-union after shoulder arthrodesis is probably 10 to 20%, right? But here, I thought this was a slam dunk, right? Because you look at Cofield's method, 3 screws, or Robin Rich's putting the plate on. I just used the 3 screws there because I was cutting her arm off, all right? I was doing an above elbow amputation. She was going to have no lever arm whatsoever, all right? I didn't even have to do anything. If anything's going to fuse, it would be this. Didn't fuse. I had to go back and put a plate on and everything else. And then ultimately she never actually wore an implant, but she actually felt better because of the pain. So these are very unusual circumstances that you're going to do fusions in. Fusion is the right answer on your board exams, right? But practically, I think it's hard to get patients to do it, right? If they think there's another option.
Yeah, I was actually intrigued by your iatrogenic rotator cuff disease due to shoulder replacement, and any measures to prevent it, to minimize it, and how do you factor this in your decision to put primary, shoulder replacement versus reverse?
Yeah, you mean the amount of damage we potentially do to the. Well, listen, it's hard to quantify that because rarely do you tear the rotator cuff while you're operating on it. All right, but think about it. You're putting the arm in extension, you're externally rotating, you're putting a retractor, let's say a small Homan, underneath the rotator cuff, levering it back so you can get it exposed. You're doing some damage to that. When you're older and there's some rotator cuff compromise, I think it takes its toll. I assume it's going to be okay in younger patients, 60s, maybe early 70s, and you get a sense of the rotator cuff. The rotator cuff can look like it's robust tissue, or it can look like it's bearing the effects of use, right? It's those patients that worry me. How do I try and minimize it? I try and be very careful with how we manipulate the shoulder, but it's a very difficult thing to quantify. But those are the patients, I think, that afterwards they don't get the range of motion that you think, because I think we basically knocked off the rotator cuff. Now, I think that's more likely to happen as they get older. That's why when they're starting into their 80s, if I think there's any rotator cuff compromise, I'll go to a reverse, right, to avoid that.
So as a follow-up, as part of your preoperative workup, are you getting MRIs on patients or MRI with contrast to see if there's partial thickness tears, looking for tendinopathy on the MRI?
Yeah.
What sequence would you look at on an MRI to judge that for yourself so whether you can counsel the patient appropriately? I'd like to do an anatomic and have a reverse in my back pocket just in case I get in and I'm not happy with those.
So I get CAT scans on everybody. I don't get MRIs on anybody except an unusual situation, right? Because Now, keeping that in mind, frequently they come to me with an MRI, right? Because they've had somebody else has gotten it somewhere, right? So it's not like I don't have access to 30 to 40% of them. I don't use the MRI so much as an indicator when the rotator cuff is intact, right? And I don't have a good reason for that, other than the fact I still think that I've seen enough of these that I can actually understand it. If you operate on anybody in their 60s or older, an MRI is going to show partial thickness tearing. There's no doubt about it, right? What you'd like to see is if for some reason they've got significant rotator cuff atrophy. That may be more than you would expect, even with an intact rotator cuff. And you see that. When you get MRIs of patients for rotator cuff disease or otherwise, they'll say the rotator cuff will be intact but thin, but they've got significant atrophy of the rotator cuff. That's a bad sign. That would be a reason for me to get that, but I haven't done it as yet. So you make a good point. That was a good question. You hear that? Okay. That was better than yours. All right. Okay. Okay. Yeah. Exactly.
So out of fairness, Charlie Rockwood was here in your position maybe 6 years ago, and he said, as you mentioned, that glenoids were bad. Now, why do you think? Is it really just simply that they're hard to put in or harder to put in? Is that really the basis for the controversy? Or are there those out there that experience early failures, and that's pushing them toward just doing the thing?
Well, if you look at the incidence of radiolucent lines after glenoid insertion, it's very high, right? And there was a study that said if you get the right post-op films, the immediate post-op films, it's 30-40%.
Right.
So radiolucent lines does not equal loosening.
Right.
Loosening does not equal revision. I've got a lot of patients in my practice 6, 8, 10, 14 years after shoulder replacement, their glenoids are radiographically loose. But I'm not doing anything about it because it's not an issue for them.
Do you think they function better than those with the hip?
I think so because I think, but it remains to be seen. Now with a hemi, I think there is inevitably going to be glenoid erosion, right? It's going to erode over time, no doubt about it, right? And Charlie also was talking about not replacing the glenoid, but he wasn't making a big emphasis on, restoring concavity, shaving it, doing the reaming to reshape it and things, which I'm not sure is necessary either, right? But certainly you want to center it. I think the worst situation is if you've got a hemi that's uncentered on the glenoid, then you just keep wearing it out because it's not balanced. So now, I would never say that Charlie Rockwood, couldn't put a glenoid in. All right, okay. I'd never say that at all. All right, but I think when somebody who's as experienced as he is says that it's comparable, listen, 80% of shoulder or more shoulder replacement in this country are done by people that do a few a year, right? So and in their hands, right, it becomes a justification not to do the glenoid, which I think is a misdirection. Yeah.
Why do you think scapular notching occurs after reverses, and what do you think the impact truly is clinically?
Yeah, it's a design issue, all right? They just missed it, all right? It has to do with the fact that it's the angle of inclination of the humeral component and the fact that the humeral component in those designs is inset, all right? That's what it is, all right? It's a design flaw, right? We looked at our scapular notching, which is designed differently. Ours is on top of the humerus. It's a different angle. And our scapular notching was about 9% at 2 years. None of them will be on stage 1 or stage 2, all right? Other designs have not had scapular notching problems. Now, so how the Grammont design, how have they addressed this, right? Well, the first way they addressed it is by saying it wasn't a problem. Then when it was evident it was a problem, now they do things like this bio-RSA. So you know what that is? They take bone from the humeral head and they put it between like I showed you there on that glenoid case, they put bone between the humeral head and from the humeral head, put it on the back of the glenoid and interpose it between the glenoid and the native glenoid and the prosthesis. So that lateralize it, and then they angle it a little inferiorly to correct it. So basically, they're correcting a design flaw. So that's what it is, right? Now, why I would ever want to put a bone graft in that and now have two surfaces that have to heal, right, is beyond me, all right? But people are jumping on the bandwagon about this.
So you don't think that the inferior tilt is necessary?
It is in certain designs, absolutely, all right? I don't think you have to do it in all designs. Mark Frankel didn't, in his design, he hasn't had any scapular notching. That's a more lateralized center of rotation. right? So it gets it away from the glenoid. So think about it. We heard a lot about scapular notching, 4 or 5 years ago. It was a big deal. Now nobody's talking about it anymore, right? Because the newer designs, that whole slide I showed you there, I think have addressed it with this design.
Any other questions? So because you're here, I'm going to put you on the spot.
Okay.
I'm going to diverge away from arthroplasty for a moment to maybe briefly present a case that we have. Jamie, our patient with the multi-directional instability. Could you describe this patient and maybe get some thoughts from Dr. Zucker? You got to speak up.
So why don't you come up here?
Could you show the slides?
You sure you don't want to come up here? Yeah, come.
We're going to get her to stand up. Stand
Yeah.
up. You can stand up and respond.
Okay, so it's a 23-year-old male in our prison population that has had recurrent shoulder dislocations. He has a significant amount of bone loss, significant health sac lesion. And because of his recurrent dislocations, we pinned him with a...
And what's the recurrence?
Voluntary, whatever.
Voluntary, and I think he was there 1 week, and the next week again he was back in our unit for a dislocation. And so we put a huge stymie pin in to keep him reduced, and we're bringing him back, and we were thinking about doing a lateral shave procedure.
So what's been your experience with
Okay.
direction?
So he's multidirectional because he's not just dislocating anteriorly.
What's that?
He's not just dislocating anteriorly. So it's inferiorly, anteriorly, posteriorly. Okay. So you got to understand the pathoanatomy of what's going on there. All right. Now the pathoanatomy of any instability relates to bone and soft tissues. Now you mentioned something about he's got a Hill-Sachs. Right? Not all Hill-Sachs defects are created equal. There are big ones, there are small ones, there are engaging ones, non-engaging ones, right, et cetera. So you got to understand the anatomy of the Hill-Sachs. That's number one. As you said, there's glenoid erosion, right, because you're thinking about doing a lateral. That indicates that there's significant anterior glenoid wear. You got to understand that to a certain extent, right? Then you have to look at the soft tissues. Clearly, he's got secondary soft tissue instability, right, incompetence, right, from the capsulolabral detachment, right, but that's anteriorly. Posteriorly, I have to understand that a little more, all right, because he's going out posteriorly as well.
It's hard to say for sure, but I think that he is a
Okay, okay. Well, multidirectional can mean a lot of things, right? But this guy, the true multidirectional instability patient, right, is the person who doesn't have a whole lot of bony findings, right? It's a soft tissue incompetence that allows them, it's basically, it's instability that's superimposed on significant soft tissue laxity, right? Now think about the concept of translation and instability. Every humeral head translates around the glenoid. There are some people you can translate it out 50% each direction and they're asymptomatic. The moment they become symptomatic, that's when translation becomes instability or subluxation. So the true multidirectional that I like to think about is somebody that has purely soft tissue problems. That's the way it was described in the original series. What you've got is somebody that has a grossly unstable shoulder in multiple directions with significant bony deformity, right, and associated soft tissue problems. The way to address that is basically you have to try to correct the anatomy, right? Now that may mean the lateral may address it one thing. He's basically talking about a glenoid bone graft. A lateral may not be sufficient to that. It all depends on the degree of glenoid bone that's lost. Do you do anything with the Hill-Sachs? It depends on its size, right? There may be a reason to graft the Hill-Sachs, right? With an allograft or do a remplissage, right? I've never done that, right? But I know that's becoming in vogue. But the larger it is, they have to fill the defect, right? Then you have to understand the soft tissues, which regardless, right? If you do any kind of lateral, you still have to do a soft tissue reconstruction, right? Which for me is always going to be some type of capsular shift or anteriorly. And if he's truly got some posterior instability, then you can maybe be able to tighten it up from the front sufficiently in the back. And if they're, and when you got this whole thing finished, all right, you got to put this guy, all right, immobilize him. If he's a citizen, you put him in a gunslinger, all right, in neutral, all right, okay? But if he's not a citizen, you put him in a spica. Because the other thing you started off with, all right, is the fact that he's in prison, all right, and he's voluntary. Now keep in mind, the voluntary patients, there's two types of voluntary patients. There's the classic one, you know, adolescent who's doing this, making their shoulder go in and out for attention, etc. Now, this gets him out of the general prison population, all right, and that's probably a factor as well. So you have to see if you can figure that out. But to me, an understanding of the pathoanatomy, right, is most important in how you're going to correct this. Do you ever hear of something called a derotational humeral osteotomy? Yeah. So years ago, this sort of reminds me, I had a prisoner, right, that I was taking care of, right, with something similar, bad glenoid erosion, right, and a big heel sacs defect. So I did a glenoid bone graft from his iliac crest and a derotational humeral osteotomy. Why? Well, I didn't need the slide for a talk, all right? That was one thing, all right? Because that way I felt I could address both, all right? And I actually made him stable, at least, you know, for as long as, I think he was only in jail for 2 or 3 years. I don't know what happened after that. But again, addressing the anatomy is what you have to do, but don't neglect the soft tissues and immobilize this guy, all right? That's for sure, all right?
All right. Nacho, thank you very much.
All right.